Everyone. So, as a routine, it's another our bright Monday, and I have not seen any online conferences, online lectures where people join, 40 people join before we start the lecture. So, this shows that what and how beautifully we speakers are and moderators are taking, and these lectures are useful. And today's lecture is extremely useful, where we will discuss antipsychotic drugs. And this lecture will be dealt by TMS team under moderatorship of Dr. Jayita. We know Dr. Jayita very well, but those one or two people, if they have joined newly, then Dr. Jayita is head of the Department of Palliative Medicine at TMH Hospital and working extensively in area of palliative medicine, as well as he's an extraordinary human being and very good friend of everyone in India as a palliative, those who are working in palliative medicine. I request Dr. Jayita to introduce Dhanashri. Although I have in front of me CV is there, but Dhanashri is her student, so she will be able to narrate her and then start. Please go ahead, Jayita. Dr. Jayita, you can start.
Thank you. Can you hear me?
We can hear you, yeah.
Can you hear me? Yes. Good morning, everyone. Thank you, madam, for your kind words for me and our team. It is my pleasure to introduce our student, Dr. Dhanashri Kudal. She is in her second year of palliative medicine. She's currently working in non-oncology palliative care in KEM Hospital. She is very good, interested in learning, and she never hesitates to ask for help when she is learning something new. As you can see, she has done the specialized ECOP. She did a poster presentation in IAPC 2022, and her areas of interest are neuropalliative care, palliative medicine in oncology settings, and renal palliative and supportive care. As a person, Dhanashri, from her, I can see that she is a very strong and firm person, but at the same time, she will never hesitate to ask for help from all her friends and colleagues and seniors. So she and I have prepared this presentation for today with, of course, maximum effort from Dhanashri. So over to you.
Thank you, ma'am. Should I start screen sharing?
Yeah, you can start screen sharing. Please go ahead.
Good morning to respected teachers, my seniors and my colleagues. Today, I'm here to present a seminar on topic antipsychotics in palliative care. Topics to be covered today are introduction, classification of antipsychotics, dopamine receptor antagonist, serotonin dopamine receptor antagonist, antipsychotics and their receptor action, pharmacokinetics, clinical use, current evidences and guidelines and recommendations for use, switching antipsychotics, adverse effects, immediate and long-term and its management, cautions and precautions, drug interactions, recommendations for Indian setting. Introduction. Medication used to treat psychiatric disorders are sometimes referred to as psychotropic drugs. These drugs are commonly described by their primary clinical applications, for example, antidepressants, antipsychotics, anxiolytics, mood stabilizers, hypnotics, etc. They have multiple indications. For example, the serotonin dopamine antagonists are both antipsychotics as well as mood stabilizers. Classification. Antipsychotics are classified as dopamine receptor antagonists, that is first generation or conventional antagonists. Antipsychotics. Further, they are classified as phenothiazines, includes chlorpromazine and thioridazone. Then butyrophenones like haloperidol and thioxanthines. Second classification includes serotonin dopamine receptor antagonist or second generation antipsychotics or typical antipsychotics. In that, less sedating includes risperidone and more sedating includes olanzapine and quetiapine. Next, dopamine receptor antagonist or first generation antipsychotics or typical antipsychotics share the primary pharmacological property of D2 antagonism, which is responsible not only for their antipsychotic efficacy but also for many of their side effects. The therapeutic action is due to blockade of D2 receptors, specifically in mesolimbic dopamine pathway. Administration of D2 antagonists such as conventional antipsychotic blocks the dopamine from binding to D2 receptor, which reduces hyperactivity in this pathway and thereby reduces positive symptoms as well as, for example, delusions and hallucinations. The mesocortical pathway. It is from dorsolateral prefrontal cortex and to ventromedial prefrontal cortex are hypothesized to be hypoactive, leading to cognitive symptoms like blunting, anhedonia, and apathy. Next one is nigrostriatal dopamine pathway arising from substantia nigra. Regulates extrapyramidal symptoms that reinforces movement with desired outcome. But blockade of D2 receptors by conventional antipsychotics can cause extrapyramidal symptoms like, for example, tardive dyskinesias and neuroleptic malignant syndrome. Tuberoinfundibular pathway. It projects from hypothalamus to pituitary gland, responsible for inhibition of prolactin normally. D2 antagonist here causes prolactin levels to rise, leading to galactorrhea. Conventional antipsychotics have pharmacological properties in addition to dopamine D2 antagonism. The receptor profile differs from each agent, contributing to divergent effect profiles. However, some important characteristics that multiple agents share the ability to block muscarinic cholinergic receptors and histamine receptors, as well as alpha-1 adrenergic receptors. Then serotonin dopamine receptor antagonist. Atypical antipsychotics have clinical profile of equal positive symptoms by antipsychotic actions, but low extrapyramidal symptoms and less hyperprolactinemia compared to conventional antipsychotics. Since almost all the agents came from introduction of clozapine, sometimes atypical antipsychotics are also called as second generation antipsychotics. From pharmacological perspective, the current atypical antipsychotics as a class are defined as serotonin dopamine antagonists with simultaneous serotonin 5-HT2A receptor antagonism that accompanies D2 antagonism, representing dual pharmacological action. Then beneficial actions and receptor activities for selected antipsychotics. Chlorpromazine, it has reduced extrapyramidal and negative symptoms with help of 5-HT2A receptors. It has anxiolytic effect by acting on alpha-1, H1 and muscarinic receptors. Clozapine, it has similar action as that of chlorpromazine, but is partial agonist to 5-HT1A receptor. Olanzapine, it reduces extrapyramidal symptoms and has anxiolytic effect by acting on H1 receptors. Haloperidol, it has potent D2 antagonism by reducing positive symptoms and has anxiolytic effect by acting on alpha-1 adrenoceptors. Then quetiapine is partial agonist of 5-HT1A receptor and has maximum anxiolytic effect by acting on alpha-1 and H1 receptors. Risperidone is potent D2 antagonism, reduces positive symptoms, and it reduces extrapyramidal symptoms by acting on 5-HT2A receptors. It has antidepressant action by acting on alpha-2 receptors, as well as alpha-1 receptor helps in its anxiolytic actions. Now we will see in detail haloperidol. It binds potently to D2 receptors as well as omega D3 receptors and alpha adrenergic receptors. Olanzapine, it binds to several receptors more potently than it does to D2 receptor. In fact, strongest potency for H1 and 5-HT2A receptors. Its 5-HT2C antagonist properties may contribute to its mood and cognitive symptoms. Although together with its antihistaminic properties, they could also contribute to its efficacy for mood and weight gain. Quetiapine. It does not actually have particularly potent binding to D2 receptors. Its prominent alpha H1 antagonist properties has ability to improve sleep disturbances, but may cause daytime sedation, especially combined with M1 muscarinic and alpha-1 adrenergic antagonist properties. Its metabolite norquetiapine may contribute additional action on receptors. Risperidone is potent D2 antagonist with alpha-1 antagonist properties, contributes to orthostatic hypotension. Aripiprazole, it is partial agonist to D2 receptors rather than an antagonist. And additional properties include 5-HT2A antagonism, 5-HT1A partial agonism, and 5-HT7 antagonist with 5-HT2C antagonism. Weak binding potency at receptors associated with sedation. Chlorpromazine. This figure portrays about binding properties of chlorpromazine. Mainly action is mediated through D2 receptors, but also binds potently to alpha-1, D3 receptors, and H1 receptors and many other. Antiemetic actions are associated with several receptors, including D2, 5-HT2, 5-HT3, H1, and M receptors. Other actions implicated in an antidepressant effects include 5-HT1A and D2 partial agonism, 5-HT7 agonism, example, quetiapine and monoamine reuptake inhibitors. 5-HT1A partial agonism is also implicated in the anxiolytic effect of some antipsychotics. Then comes pharmacokinetic. Chlorpromazine has oral bioavailability of 10 to 25%. Its time to peak plasma concentration is 2 to 4 hours per oral and half-life is 30 hours. It is metabolized by CYP2D6 enzyme. Haloperidol, its oral bioavailability is 40 to 85%. Time to peak plasma concentration is 2 to 6 hours per oral and 20 to 30 minutes intramuscular. Half-life is 12 to 38 hours. It is metabolized by enzymes CYP2D6 and CYP3A4. Olanzapine, its bioavailability is 60 and time to peak plasma concentration is 5 to 8 hours. It is unaffected by hepatic or renal impairments. Therefore, half-life is 34 hours. In elderly, it is 52 hours. It is metabolized by enzyme, particularly CYP1A2 and CYP2D6. Quetiapine, its oral bioavailability is more than 75%. Time to peak plasma concentration is 1.5 hours. Its clearance is reduced by hepatic and renal impairment. So half-life is 7 hours and its active metabolite including norquetiapine half-life is 12 hours. It is metabolized by CYP3A4. In clinical use of antipsychotics in palliative care. Delirium, nausea, vomiting, terminal agitation, intractable hiccups, mania and bipolar disorders, and psychosis are some of the indications. Delirium. We can start haloperidol with 0.5 mg 24 hourly IV or per oral and subcut at bedtime with Q2 hourly PRN doses. Median effective dose is 2.5 milligram per 24 hour. If insufficient, consider switching to other antipsychotics. Olanzapine, we can start with 2.5 milligram per oral at bedtime and PRN doses. Mean effective dose is 5 milligram 24 hourly. Risperidone start with 0.5 to 1 milligram per oral at bedtime and PRN mean effective dose of 1.5 milligram 24 hourly. Quetiapine start with 12.5 milligram per oral BD doses. Mean effective dose is 20 to 75 milligram Q 24 hourly. Here are some references. Association of antipsychotic dose with survival of advanced cancer patient in delirium. It was a prospective observational study. Modest dose response to survival of antipsychotics dosing for delirium in terminally ill patients to minimize the potential mortality risk for management of delirium in advanced cancer patients. Both typical and atypical antipsychotics should be started at low dose and titrated carefully. Second is effect of antipsychotics and non-pharmacotherapy for management of delirium in people receiving palliative care. It is individualized treatment targeting underlying cause should remain cornerstone in delirium management in patients receiving palliative care. In cases of mild to moderate delirium, a study done by Mira Agar, efficacy of oral risperidone, haloperidol, or placebo for symptoms of delirium among patients in palliative care. It was a randomized clinical trial. Participants with placebo had better overall survival than those receiving haloperidol, but this was not significant for placebo versus risperidone. Then there was a study by David Hui. That was effect of lorazepam with haloperidol versus haloperidol alone on agitated delirium in patients with advanced cancer receiving palliative care. In addition to lorazepam and haloperidol, compared with haloperidol alone, resulted significant greater reduction in agitation at 8 hours. ESMO guidelines recommendations include management of potentially reversible causes of delirium episode, non-pharmacological management, pharmacological management including haloperidol and risperidone to demonstrate benefit in mild to moderate delirium is less. Olanzapine, quetiapine, and aripiprazole may offer benefit in symptom management of delirium. Then nausea, vomiting. Haloperidol should be started 0.5 milligram to 1.5 milligram Q24 hourly per oral subcut or IV doses at bedtime. Q2 hourly PRN doses to maintain with 0.5 milligram to 10 milligram 24 hourly. Olanzapine started with 2.5 to 5 milligram per oral at bedtime. Typical effective dose of 2.5 to 5 milligram Q24 hourly used in chemotherapy regimens. Chlorpromazine per oral, it should be started 10 to 25 milligram every 4 to 6 hourly plus PRN doses. IV and IM dose, we can include 25 to 50 milligram Q 4 to 6 hourly plus PRN doses. Levomipramazine to start with 6.25 milligram per oral subcut at bedtime and 2 hourly PRN doses to up to 25 milligram 24 hours. Here was study of olanzapine 5 milligram plus standard antiemetic therapy for prevention of chemotherapy-induced nausea vomiting, J-FORCE, in which olanzapine 5 milligram combined with palinocetrone and dexa can be new standard antiemetic therapy for patients undergoing cisplatin-based chemotherapy. Also, olanzapine was compared to placebo in a study by Rudolph. It improved significantly nausea prevention as well as complete response in patients receiving highly emetogenic chemotherapy. Then terminal agitation. Haloperidol started with 1.5 to 5 milligram subcut dose stat and Q1 hourly PRN doses. Median effective dose is 2.5 to 10 milligram 24 hourly. Levomipramazine second line given only if intended to reduce level of consciousness. Start with 25 milligram subcut dose, Q1 hourly PRN doses and maintain with 50 to 200 milligram 24 hourly continuous subcut infusion. Terminal agitation. article by David, who conducted that 3 strategies of neuroleptics might reduce agitation in patients with terminal agitation. It included haloperidol IV by increasing the dose, or rotation to chlorpromazine, or combined haloperidol with chlorpromazine. Intractable hiccups. Haloperidol should be started with 1.5 to 3 mg per oral BD dose or TDS dose, maintained with 0.5 to 1 mg TDS. Chlorpromazine per oral 25 to 50 mg Q6 to 8 hourly. If hiccups persist, even after oral treatment of 2 to 3 days, chlorpromazine is given as IM or IV dose. Anorexia and cachexia. In open studies, olanzapine improved cancer-related anorexia. Because of frequent increase in appetite and weight, a potential role of olanzapine in cancer-related anorexia is being explored. Benefit is reported with olanzapine either alone, as low as 1.5 mg to 24 hourly dose, or in combination with megestrol, but has not been confirmed in an RCT. Behavioral and psychological symptoms associated with dementia. Its occurrence has been documented in most types of dementias like Alzheimer's disease, vascular dementia, dementia in Parkinson's disease, and frontotemporal dementia. Predominantly, the compromise of agitation and mood disorders, psychosis, disinhibited behavior, impairment of sleep and wakefulness rhythm, wandering and shouting, etc. Antipsychotics daily dosing include 2.5 mg to 7.5 mg of olanzapine, either tablet or injectable form, risperidone tablet form 0.25 to 1 mg, quetiapine tablet form 12.5 to 150 mg, aripiprazole or injection 5 to 10 mg, and haloperidol tablet or injection 0.5 to 5 mg. Other indications includes psychosis. Olanzapine dose is 10 mg per oral at bedtime. As a starting dose, quetiapine 12.5 to 25 mg per oral can be titrated over 3 to 4 days. Risperidone starting dose of 2 mg per oral at bedtime. In mania, olanzapine is 15 to 20 mg per oral. Quetiapine includes 50 mg per oral BD dose at starting. Risperidone 2 mg per oral at bedtime. In treatment-resistant depression, 5 mg per oral dose of olanzapine at bedtime. Quetiapine 12.5 to 25 mg per oral BD doses. Quetiapine's its antipsychotic median effective dose is 800 mg. Its antidepressant effective dose is 300 mg, and as an hypnotic, median effective dose is 50 mg. Now we will see some case scenarios. 40 years old male, known case of metastatic carcinoma of buccal mucosa with lung metastasis, presented with altered sensorium since 2 days. Relatives informed that patient had irrelevant talks and was agitated at times. On examination, patient was looking dehydrated. Blood pressure was 80 by 60 mm of Hg with saturation of 96% in room air. Pupils were bilaterally reactive to light. He was on best supportive care only, no cancer-directed treatment. On investigation, he has raised creatinine of 3.5, suggestive of acute renal injury with hypercalcemia. His corrected calcium was 16. Apart from measures to correct hypercalcemia, which antipsychotic would you prefer in delirium? First line antipsychotic used in many of the centers is injection haloperidol with a dose of 1.5 to 5 mg for hyperactive delirium. Second case scenario. 65 years old male, known case of metastatic lung cancer with nodal liver metastasis, having complaint of headache, nausea and vomiting since 3 days. Intermittent hiccups since 2 months, now worsened since 5 days. Patient was not currently on cancer-directed treatment. His blood investigations showed hyperbilirubinemia of 5. On MRI scans, he had progressive brain lesions, suggestive of metastasis. After receiving medications and whole rate radiation therapy for raised ICT, his symptoms improved. But his activity of daily living was affected due to intractable hiccups, which was not relieved on tablet baclofen 20 mg twice a daily dose. He had no GRD symptoms as such. Which antipsychotic would you consider here? Chlorpromazine and haloperidol are authorized for intractable hiccups, but their reported benefits remain unconfirmed by RCTs. Thus, they are used when more specific treatment, example, metoclopramide for gastric distension or baclofen, is ineffective. Then switching antipsychotics. Equivalent doses of typical antipsychotics have been estimated. Firstly, provide a starting point if switching per oral from one to another. Equivalent subacute doses can be estimated from their bioavailability. However, doses of atypical antipsychotics are less variable, and starting doses are generally unaffected by the dose of previous antipsychotics. Chlorpromazine per oral dose of 100 mg. Haloperidol per oral dose of 3 mg and levomipramazine per oral dose of 50 to 100 mg. Adverse effects. System-wise, cardiovascular system adverse effects are postural hypotension. Mechanism is by alpha-1 antagonism, most commonly seen with quetiapine and levomipramazine. QT prolongation mechanism is potassium channel blockade. It is higher in cases of quetiapine, and mild to moderate risk is seen with haloperidol. Stroke and mortality. Mechanism is unknown. Venous and thromboembolism, here the mechanism is unknown. It is more seen with olanzapine and levomipramazine. Metabolic side effects including hyperprolactinemia caused by D2 antagonism is most common with haloperidol, risperidone, and levomipramazine. Weight gain, dyslipidemia, and type 2 diabetes mellitus. Mechanism is H1, 5-HT2C, and M3 antagonism, common with olanzapine, quetiapine. Extrapyramidal side effects. Mechanism is D2 antagonism, common with haloperidol and levomipramazine. Miscellaneous effects include agranulocytosis, dry mouth, constipation, lower seizure threshold, and sedation. Agranulocytosis is immune-mediated. Dry mouth and constipation is due to M1 and M3 antagonism, more common with levomipramazine. Lower seizure threshold mechanism is unknown, but more common with clozapine. Sedation is due to M1, H1, and alpha-1 antagonism, more common with olanzapine, quetiapine, and levomipramazine. Cardiac effects and QT prolongation. The dopamine receptor antagonist decreases cardiac contractility, disrupts enzyme contractility in cardiac cells, increases circulating levels of catecholamines, and prolong atrial and ventricular conduction time and refractory periods. Phenothiazines are usually more cardiotoxic. Haloperidol has been linked to abnormal heart rhythm, ventricular arrhythmias, torsade de pointes, and sudden death when injected IV. Chlorpromazine also causes prolongation of QT and PR intervals, blunting of T waves, and depression of ST segments. So drugs that has potential to cause QT prolongation should not be used together. Here is an article which compare antipsychotics for treatment of patients with delirium and QTC interval prolongation. Here they mentioned quetiapine has severe risk and haloperidol has mild to moderate risk of QTC prolongation. Endocrine and metabolic syndrome. Blockade of dopamine receptors in tubuloinfundibular tract results in increased secretion of prolactin, which can result in breast enlargement, galactorrhea, amenorrhea, and impotency seen in men. The SDAs except risperidone are not significantly associated with an increase in prolactin levels and may be the drug of choice for persons experiencing disturbing side effects from increased prolactin levels. Weight gain is associated with increase in mortality and morbidity with medications non-compliance. Low potency DRS may cause significant weight gain, but olanzapine and clozapine has greater potential. Hyperglycemia may develop with secondary to weight gain associated with insulin resistance or to other remains to be clarified. Hyperlipidemia is also seen in patients and monitoring of lipid levels should be done. Higher level indicates increased risk of atherosclerotic and cardiovascular diseases. Then antimuscarinic activity. Blurring of vision, increased intraocular pressure, dry mouth and eyes, constipation and urinary retention. Sedation and cognitive effect. Decreased seizure threshold. Clozapine has higher risk and haloperidol has the lowest risk of seizure threshold. Leukopenia and agranulocytosis and urticarial skin reactions. Extrapyramidal side effects are due to D2 antagonism, nigrostriatal dopamine pathway arising from substantia nigra, regulates extrapyramidal system that reinforces movement in desired outcome, but blockade of D2 receptors by DRS can cause extrapyramidal symptoms, include reversible, like Parkinson's. Symptoms include tremors, rigidity, akinesia or bradykinesia, acute dystonias, muscle spasm, oculogyric crisis, torticollis, akathisia, motor restlessness. Irreversible includes tardive dyskinesias, involuntary movements developing in face and limbs after months or years of antipsychotic treatment, includes tongue thrusting, chewing, rabbit lip syndrome, grimacing, blinking, coriform movements of extremities. Next comes neuroleptic malignant syndrome. Differential diagnosis includes serotonin syndrome and anticholinergics. It is potentially life-threatening, idiosyncratic reaction to starting or increasing the dose of dopamine antagonist or abruptly stopping anti-Parkinsonian dopamimetics. Requires 4 features explained by other diagnosis. That is recent dopaminergic medication change, severe muscle rigidity, pyrexia, more than 2 features altered. That is consciousness, dysphagia, incontinence, mutism, sweating, tremor, tachycardia, labile blood pressure, leukocytosis, raised CPK enzymes, and myoglobinuria. In treatment, muscle relaxants like benzodiazepines or dantrolene. Dopamimetics example, bromocriptine continued for 10 days. Supportive care with hydration. Prognosis results in 1 to 2 weeks. Residual extrapyramidal side effects can occur, particularly if treatment is delayed. 10% mortality rate is seen. Recurrence of rate is 30 to 50% if antipsychotic associated and an alternative is tried. It is rarest. It is defined as delayed effect of antipsychotics. Rarely occurs after 6 months of treatment. The disorder consists of abnormal, involuntary choreoathetoid movements of muscles, heads, limbs, and trunk. Perioral movements are most commonly including darting, twisting, and protruding movements of tongue, chewing and lateral jaw movements, lip puckering, and facial grimacing, etc. Treatment includes reducing dose of antipsychotics. In 2017, FDA approved valbenazine for treatment of adults with tardive dyskinesia, making this first approved medication. Also, benzodiazepines and carbamazepine reduces symptoms of both movements and psychosis. Then comes cautions and precautions. Stroke risk and mortality. Meta-analysis of RCTs in elderly with dementia indicates that risk of stroke and death with antipsychotics is less than 2 to 1.6 times higher respectively compared with placebo. Cardiovascular diseases. All antipsychotics have potential to predispose to arrhythmias through muscarinic antagonism and QT interval prolongation. Link between prolonged QT interval and torsion D point exists for haloperidol and levomipramine. Seizure risk. Clozapine carries highest risk and haloperidol probably the lowest. Parkinsonism and Parkinson's disease. All antipsychotics through D2 antagonism can cause or exacerbate Parkinsonism. The risk is lowest with clozapine and quetiapine. Hepatic impairment. Highly protein bound and extensively metabolized in liver by one or more of the CYP3A4, CYP2D6, and CYP1A2. Haloperidol is significantly having biliary excretion of drug as well as active metabolite. Here we can consist of half the initial doses. Olanzapine has long half-life. Lower starting dose is recommended. Increase with caution is done. Quetiapine, shorter half-life. Clearance reduced by 30% in patients with hepatic impairment. Lower doses needed and should be started with 25 mg per day. Risperidone, lower doses needed in hepatic impairment. Start with 0.5 mg BD dose. Avoid in hepatorenal syndrome. Levomipramine, long half-life. If unavoidable, per oral or subcutaneous dose, start with 2.5 to 3.125 mg HS. Renal impairment. Haloperidol less than 1% excreted unchanged in urine. Cautions in renal failure. Olanzapine 57% is excreted mainly as a metabolite through urine. Glomerular filtration rate is less than 50 ml per minute, start with 5 milligram per day. Quetiapine less than 5% excreted unchanged in urine. Plasma clearance reduced by average of 25% in patients with GFR less than 30 ml per minute. GFR less than 10 to 50 ml per minute, start with 25 milligram per day dose. Risperidone avoid if possible. Active metabolite accumulates in renal impairment and removed with dialysis and start with 0.5 milligram dose. All these guidelines are from Maudsley. Drug interactions. Antipsychotics have tendency for prolongation of QT interval, increasing risk of tachyarrhythmias and leading to fatal torsady depointes. Therefore, concurrent prescription of drugs below with antipsychotics should be avoided. Includes antiarrhythmics, that is amiodarone, sotalol, flecainide, and dronedarone. Antidepressants like citalopram and escitalopram. Antimicrobials include fluconazole, quinolones, and macrolides. Antimalarials includes chloroquine. Miscellaneous include cocaine, propofol, methadone, ondansetron, domperidone, and oxaliplatin. Serious interactions may result from concurrent use of antipsychotics with potent inhibitors and inducers of CYP450 enzyme, resulting in undesirable effects or failure of treatment. CYP1A2 is an enzyme for which substrate is olanzapine, inhibitor is ciprofloxacin and cimetidine, inducers are phenytoin, rifampicin, and tobacco smoking. CYP3A4, 5 substrate is hydrolol, inhibitors are clarithromycin, aprepitant, ciprofloxacin, fluconazole, oriconazole, and inducers are rifampicin, phenytoin, phenobarbital, and carbamazepine. CYP2D6, substrate is risperidone, and inhibitors are duloxetine, fluoxetine, cimetidine. Severe neurotoxic or extrapyramidal undesirable effects have been reported with lithium and several antipsychotics, including haloperidol, levomipramazine, and quetiapine. Here are some recommendations for Indian setting. Clinical practice guidelines for management of delirium in elderly case reports given by Sandeep Grover, and olanzapine in treatment of refractory nausea vomiting in palliative care settings given by Nishkarsh Gupta. Thank you.
Thank you very much, Dhanashri. I have been simultaneously posting some additional points when Dhanashri has been going through the slides. But please feel free to put your questions on the chat, and I will try and answer. And there are some points that I need to reiterate, which I will do so. Yes, Dr. Neetu, haloperidol can be safely used in obstructive jaundice, and nothing is safe. We always, because you saw that for a long time, I was under impression that haloperidol is very safe in hepatic impairment, and it is with the time that I realized that it is not so. So we have to start with it is probably the safer one that we use, but we have to start with very low dose and then check. As I've written there already, for hepatic impairment in use in psychiatry for psychotic disorders, the ones they prefer are sulfuride and amisulfuride. And both these drugs, we do not really use them in our practice, and we don't have any experience, and there's not much literature in that. So that is my answer. I would still go with haloperidol in OJ, but in very small dose. And thank you, Mary, for appreciating Dhanashri's presentation. Any other questions, please? I think Dhanashri is finished quite in time so that we have time for discussion. So in the time that you are thinking of questions, I would like to reiterate certain points. One is that what doses of antipsychotics that are used in palliative care is absolutely very minimal to what is used in psychiatry. So as you saw, that olanzapine, which we use 2.55, maximum will go up to 7.5, minimum, the usual dose is 20 milligrams. Haloperidol can go up to as much 50, 60 milligrams sometimes in psychiatry. Risperidone is about 1 to 6 milligrams per day. Quetiapine, you saw it is about 600 to 800 milligrams per day, and we don't go to go more than 50 to 75 milligrams. So that is one point. Second point is it was mentioned, Kalpana asked, it was mentioned that haloperidol can be started at 0.5 milligrams per delirium. It is always the lowest possible dose that we need to start with. So 0.5 milligrams. Problem happens is because sometimes the dose strength of the tablet are not in measure with 0.5 milligrams. Sometimes we get the 1 milligram or the 0.5 milligram tablet. We in our hospital get 1.5 milligram tablet. So we usually start with a half of that tablet. And for even injections, if we have to do, we can then make it 0.5 to 1. But the conventional wisdom is start with the lowest possible dose, and that is what is 0.5 milligrams. What would be the choice of drug for delirium, agitation in heart failure patients? In all our evidence searching for this presentation and otherwise, I haven't found anything which is specific to heart failure patients. So we need to go by conventional guidelines for delirium in any setting. So there are guidelines for delirium in hospitalized patients. So it's the same sort of algorithm about treating the cause, treating the symptoms. We will have to be extra careful in heart failure because of all the QTC prolongation that you get in both typical as well as atypical antipsychotics. So it would still be, if it is agitation. If it is agitation, that means something needs to be done. So again, conventional wisdom, treat the cause, non-pharmacological measures, and if required to use haloperidol, because as you see, all the atypical antipsychotics also have an equal QTC prolongation, and haloperidol is the one that you can use parenterally. So I would still be using that with a very, very small dose. For drug of choice for delirium in Parkinsonism, we have to avoid the typical ones in Parkinsonism, that is for sure. So that leaves us with the atypical ones. With the atypical ones, we have to see which one has the least anticholinergic effect. So risperidone risperidone has D2 antagonism in higher doses, so a very small dose. Preferably olanzapine we have to avoid because it does have anticholinergic, it does bind to the M1M4 receptor, so we have to avoid. And so that leaves really quetiapine. For anything with delirium, hallucinations and psychotic symptoms in Parkinsonism, the drug of choice is clozapine because it does not have D2, it is more D3, D4 antagonism. But for delirium, that we cannot manage with because that does have anticholinergic side effects also. So we have to see there is nothing which is a foolproof way to do it. We have to check, as I said, receptor profiles because that explains effects and side effects. I would still go with a very small dose of quetiapine, which is 12.5 milligrams, or risperidone, very small dose of 0.25, 0.5 milligrams, and then check. So again, when you are thinking about more questions. So my first point was that antipsychotic use dosage is much higher in psychiatric population, hence side effects of the NMS, the TD are more, NMS is of course idiosyncratic, but tardive dyskinesia is at least a year-long use, which we are not going to be seeing much. Second is about your guidelines for delirium. So the three papers that you saw, for four papers actually, 2016, Meera Agar and David Saro and team said that no difference between haloperidol, risperidone, placebo. In fact, placebo was better, nursing interventions was better. But this study looked at distressing symptoms in delirium and not particularly focusing on agitation. 2017, David Hui and his team looked at particularly agitation, because in all our clinical practice, that is the one that really bothers us. So 2017, David Hui said that low dose haloperidol, if we have used, we have to escalate with haloperidol and lorazepam in combination, and they found that haloperidol and lorazepam combination worked better. This was quite a groundbreaking thing, because our learning has been avoid benzodiazepines in anything but terminal delirium. So this comes in as a learning point in David Hui's study. 2018 ESMO guidelines by Shirley Bush included Dr. Meera Agar and team's recommendation from their study, saying that no, haloperidol, risperidone should not be used in mild to moderate delirium. But mild to moderate is not really our we see in clinical practice, which is we can really go treat it with non-pharmacological measures. It's a moderate to severe, with people pulling out their IV tube, wanting to go home, not actually being restless despite all the non-pharmacological interventions. It's taken for granted that non-pharmacological interventions, nursing interventions, safety measures, that's treating the cause, that is the first thing. But the agitation bit, we cannot really look at only non-pharmacological interventions. There will be times that we need to use it. And then 2020, David Hui did the study on terminal agitation, wherein he compared haloperidol, chlorpromazine, rotation to chlorpromazine, and combination. And this was good because it worked equally well in all three groups. So that I just want to make it clear, because we are always talking about evidence-based guidelines, but these there's a question. I am making Dhanashri's thing very easy, but there's a question that evidence of use of these drugs for weight gain, increasing appetite in palliative care. So if the whole symptom, the whole convention about treating the cause, treating the symptom, this is it. This is not it is always going to be an off-label use or a new practice use. So the only one that can help in this is actually olanzapine. So because it will act on the H1 receptor, hence it could be appetite as well as weight gain. Why is lorazepam preferred over midazolam in delirium with agitation? This registry is because the evidence for midazolam is in terminal delirium. For evidence for lorazepam is in other delirium related to any other cause. The maximum as in sort of a medical setting as well as in psychotic agitation is with lorazepam. But frankly speaking, in an emergency department setting, when the patient has got delirium and we have to intervene very urgently, sometimes quite a few times we would give midazolam rather than lorazepam, because it is going to be a quicker onset of action. Safest drug for insomnia in cancer patients, Dr. Vikram. As you saw, one of the off-label uses that has been used as quetiapine in 50 milligrams dose can be used as hypnotic. I, for me, use olanzapine 2.5 milligrams, because to me, one of the antipsychotics which can be used for multiple reasons. A small dose of olanzapine I find extremely useful for sleep as well as for mood and anxiety. But to be very clear, these are all off-label uses. There is nothing safest in antipsychotics. nothing safest. It is always a relative safety profile. It is to be tailored to the needs of the patient, or what is the symptom, targeted symptom, low dose, shortest period, and essentially good follow-up. Okay. So the last fourth point that I want to make is for behavioral and psychotic symptoms of dementia. These are very troublesome symptoms for people taking care of palliative care in dementia patients, and always the guidelines is always about environmental measures, social measures, safety measures, practical measures. Antipsychotics are the last, absolutely the last resort. And because they do not provide that much of benefit, but we sometimes are pushed to the wall and have to use it. Secondly, there is the QTC prolongation, increased risk of stroke, especially in the elderly, and that is equivalent amongst all the atypical antipsychotics. And of course, we cannot always deny the sudden cardiac death that can happen. So we have to have a guideline which stresses on these other non-pharmacological measures, targeted symptoms. In BPSD, we have to find out the triggers for the symptoms of agitation. Most of the times it can be just medical. It's a chest infection, it's an EGI, it is an unfamiliar surrounding, an unfamiliar staff coming in. So we have to make the plan as per the patient, and this is where person-centric care in palliative care comes in useful. Thank you very much for your comment, appreciative comment. My last point is that QTC, we cannot get away from QTC. So the network meta-analysis that Dhanashri mentioned, that was a clinical decision tree guided network meta-analysis, and this was very interesting. It was not really palliative care, it was delirium, and they saw that those who have QT of less than 450 milliseconds, amisulpride is the least culprit, and those who have more than 450 milliseconds of QT interval, QTC, quetiapine is the safest. So in taking all this, of course, we have to extrapolate a lot of these studies. That is why I think even though the risk of stroke is equal in all these APDs, sometimes delirium in the elderly, maybe quetiapine would be a better choice. There are more questions. Can antipsychotics be used early in course of disease trajectory in management of disease-induced anxiety and depression? Thank you, Dr. Sanjeev. Antipsychotics are not really the treatment of choice, drugs of choice for management of anxiety and depression. So we need to use guidelines for that. Antipsychotics can be used. Some antipsychotics like aripiprazole, olanzapine, quetiapine can be used as augmenting strategies in treatment-resistant depression, but never as first line for disease-related anxiety and depression. As always, mild features, low intensity psychosocial intervention, moderate to severe, need to consider drugs, low dose, antidepressants, and maybe benzodiazepines for a short time. Dr. Gayatri asked, what is your choice for alcohol withdrawal presenting in PC? For my choice of alcohol withdrawal, in my psychiatry practice, I would probably use diazepam. In palliative care, I am sure liver function will always be impaired, so my choice would be lorazepam. Okay, thank you, Rajesh. Thank you, Dhangal, for appreciative comment. Rajeshri, Very good summary. Thank you very much. Possible to get the additional info as well as for recording. I think whatever I have just reiterated some of the points that Dhanashri has made. All these papers she has put in the slides, and I think this recording is also going to be available. So I'm sure that will help. But all the things, all the studies that I'm telling you in detail, not in detail, a little bit more, is all that we have included in the presentation.
Thank you very much, Jayita. It was so good.
Thank you.
Very good. So, Dr. Rajri, all the recordings and whatever Dr. Jayita has narrated and described, everything is available on IAPC website. So it is going to be there. And thank you, Dhanashri. I think it was such a wonderful presentation plus wonderful moderation, Dr. Jayita. You have taken all the questions very nicely. And we have 5 more minutes. If there is any last comment anybody wants to say, just open your mic and say. Otherwise, we will stop here. Anybody wants to say anything?
Ma'am, this is Dr. Tendral. Dr. Jayita, do we need to give double prescription for any of these drugs which we have mentioned in this presentation?
Absolutely not. Absolutely not. Absolutely not. And any MBBS doctor onwards can prescribe any of our drugs. Any of these drugs, not ours, any of these drugs.
Anyone else? So if there are no comments, I just want to say one last thing, that antipsychotics are very, very useful in palliative care practice. Only thing we have to learn which antipsychotic and where and what are the safety profile. So right from the using haloperidol, I think every palliative care physician should have a very fair idea that how much haloperidol, when to use, when not to use, and what are the safety precautions of using haloperidol. Similarly, it has been proved that haloperidol and olanzapine are wonder drugs in palliative medicine. Only thing, all the residents should know how to use it. I'm not saying that these are the only two wonder drugs. There are other drugs which Dhanashri and Dr. Jayita has narrated. I think all the drugs are very, very useful, but we should know when to use and when not to use, I think. And this lecture is going to be very, very beneficial for all those who are practicing. And I think they have really gone to the very finest point, that including what are the drug interaction, what are the drug doses we should use. And please remember always, and if you forget, please follow your website, go to the IAPC website, again listen to this lecture, again see the slides. And if you have any problem, please talk to Dr. Jayita directly, that there are the or read the papers which they have we are going to put on the website. So there are few landmark papers which really guides well that what drugs should be used and when not to be used. So my take-home message from this lecture is that we should learn how to use antipsychotics safely in palliative care practice. This is very, very important. So thank you, Jayita, and thank you, Dhanashri, and thank you everyone for participating. And I'm really, really happy that today there were a lot of questions from the residents. It means residents are participating and actively listening the lectures. So please keep on asking these type of questions so that speaker will get encouraged that you are listening and you are understanding and you are learning something which is ultimately going to be beneficial for all over India. So thanks a lot, and we will see you everyone next Monday before 6:30. Please join as you are joining before 6:30. Please join as usual. Thank you, Dr. Jayita, and thank you, Dhanashri, and have a nice week. Bye bye.
Thank you.
Thank you. Thank you.
Have a great week. Thank you.